Donc, René Robert, donc, de Poitiers, va nous présenter la place des stratégies.
So, René Robert will present the place of treatment strategies in preventing AKI, moderators. Dear colleagues, the search for preventive or curative treatment of AKI in ICU is justified because AKI is frequency and moderate impairment of renal function is a factor of excess mortality, and we find it at every level. Mortality in ICU, 6 months mortality, whatever the course of renal function impairment. So for drugs to be able to act, they must act on targets. What are the targets that we can view for these treatments, be it to prevent or limit renal impairment? Ischemia, reperfusion seems an attractive target. Rise in central venous pressure, we've just seen that this could have an important impact on AKI. Inflammation via the kidneys, important. Also, a lot of associated toxics that are polluting the debate, contaminating the renal situation in our ICU patients. We can also work at the other end of the chain, that starts at the same time almost as renal aggression, that is to try and promote renal regeneration as soon as possible. And I put apart what I won't be addressing, specific renal impairment, fluids. We've just discussed fluid volume. So if I just do this poor quality focus, actually it's a very crowded chart here on the targets of potential treatments of renal impairment. Many places where we can act, in fact too many, and when there are a lot, this means that it's difficult to find a product that will act in the right place to have a relevant impact. And so if we consider what the Cadigo experts have said, well, at the end of the day, we come out pretty disappointed because, of course, we need to have the fluid balance and the optimized hemodynamic treatment. We need, of course, to control glycemia, get in the right range, and no diuretics in prevention treatment, no dopamine, no phenyldopa, no natriuretic peptides, no NAC, no growth factors, and, of course, beware of nephrotoxic drugs. Thanks for your listening. So let me nevertheless try and develop certain aspects of these various strategy, maybe delve deeper. And one of the key components of what's left is to be the best as possible in terms of hemodynamics, focusing not on mortality. It's not the top of my talk, but really focus on renal function. So, vasopressors to improve renal perfusion pressure. There's not just pressure, there's, of course, flow. Noradrenaline is no doubt the choice drug, but with what pressure purpose? I'm not the first to raise this question. The official PAM thus far tends to be above 65 millimeters of mercury in septic shock. Cadigo doesn't recommend a particular target and takes up the 75 number, maybe rise a little more, but we don't have enough work on that. We're bound to recognize that when we focus on the work of mean arterial pressure and renal function, well, we see 75 isn't better than 65, 80 is no better than 65, 75 is better than 65, 72, 82 is better than 65, only if it's septic shock or if there's AKI at H6, and possibly 75 is better than 65 in post-op heart surgery, and that improves the renal oxygenation. Couple of studies, this one by Julie Badin and Thierry Bourlin from Orléans. This is a trial involving 217 patients with shock, septic shock, 60%. and shocks, other causes for the remaining 40%. Looking at these patients at age 72, AKI, severe, with RRT, looking at the first hours, what was done to maintain pressure. There's a subgroup of interest, which is patients at H6 have or not AKI. They don't have any here. They do with septic shock, non-septic shock, septic shock patients, and we see patients without AKI at H6, whatever the level of mean artery pressure, the black squares, those with AKI at H6 and white with the others, even pressure above 65, it changes nothing in patients with AKI at H6. There, the lines separate markedly, and the pressure levels that I mentioned in the previous slide at a level slightly higher than 65 is possibly a protective factor for AKI in this situation. So, to arrive at this protective effect, that's to say, in order to have higher mean arterial pressure, there's not just noradrenaline in life, but sometimes we have to, the concentrations noradrenaline. Previous speaker mentioned this, and of course it's always difficult to say the chicken and the egg situation here. Patients where we use more noradrenaline, the squares, with septic shock or non-septic shock, the more we use noradrenaline, there's more AKI. That is, we use a lot of noradrenaline in the most severe patients. Also to be cited, trial not yet out, the sepsis PAM that was mentioned, a French multicentric led by Pierre Asfar, comparing in septic shock two pressure levels, one at 65 and one over 90. Well, in this study, I've extracted, thanks to Pierre, the subgroup of hypertensive patients, which there's less renal failure if mean arterial pressure is maintained with an objective as close as possible to 90 mm's, whereas in the general population that effect is not observed. Now, is mean arterial pressure the right metric? You've already seen this one in the previous talk, central venous pressure. I'm going to focus on two additional metrics here. Firstly, mean arterial pressure. Let me just recall, it's the Mathieu Legrand Didier Payan, 137 patients with septic shocks. They're all monitored quite sophisticatedly with heart rate. We look at SCVOT, PVC, diastolic pressure, etc. So if PVC comes out a lot as a predictive factor for AKI in these patients, however, mean artery pressure, not at all. Whatever the level we take, be it the average of mean arterial pressures or the lower mean arterial pressures or higher arterial pressures, what emerges perhaps less marked than the central venous pressure is diastolic pressure. Maybe we'll repeat the studies with a diastolic pressure and no longer the mean pressure. That's a joke, of course. Second type of drug is the insulin glucose group. Insulin, but to control glycemia, we need a lot of insulin. Of course, I can't leave this out. You'll recall that one of the results of the Vandenberg study over and above mortality was also to show that in the group with controlled glycemia, there was significantly less AKI, less RRT, but this was not confirmed by later studies. And KDIGO, in its wisdom, proposes a control relatively intermediary of glycemia, not to have overly controlled glycemia, but not to leave blood sugar too high. Need to be careful, as was said in other levels, because of too sharp of variations of glycemia, especially if there's a pre-existing hyper-G. Diuretics now, because we're bound to recognize that there's temptation to use diuretics to fight against fluid overload. Fluid overload is not good in our patients, as we've just seen. Fluid overload is not good for renal function in our patients, and because we've known for a long time that it's better to have AKI at preserved diuresis, so the temptation to transform them with the idea of having a better outcome, that idea has been around for a long time, and diuretics act, at least they act by reducing renal energy spend by reducing the energy pump for salt and water solution, and also tubular washout effect through these diuretics. As you probably know, all studies on diuretics are negative. There are even some that is demonstrated that is even dangerous, summarized in a number of meta-analyses. This one's no doubt the most. No impact on mortality of diuretics. Be used in AKI prevention or treatment once AKI is there. No impact on the use of RRT, be it in prevention or in treatment of AKI. And let's not forget the side effects of diuretics, metabolic, and also those we tend to forget, autotoxicity, notably when we use them in high doses in bolus, which is particularly ill-advised in our patients. So we've discussed fluid overload. In patients, we've seen that fluid overload is not good. Maybe a possible small place for diuretics at that point in time. We don't know what that point of time is, but this was what was studied here, which is the ancillary liberal fluid versus the restricted fluid balance. 306 AKI patients. There were 137 in the liberal group, 169 in the restricted group, slightly more. And we have the cumulative fluid balance, liberal here it's the restricted group, and we have the cumulative diuretic doses. So to reach the target in the restricted group, we have more diuretics than in the liberal group, as expected. If we now look further at the results, so fluid overload associated at J60, the D dose has a protective effect on mortality. There's hope there, but unfortunately that effect disappears after adjustment with the post-AKI fluid balance, but that's worth looking into. So the KDIGO, don't use diuretics to prevent AKI with a high level of recommendations. Grade 1B, we suggest not using diuretics to treat AKI except in the management of volume overload, pulmonary edema, for example. So this slide to get rid of dopamine at renal dose, no longer used. So for the time being, all studies say no dopamine. I've listed a number of other drugs that don't work, that have been studied fairly intensively. Phenyldopa, natriuretic peptides, nesiritide, growth factors. So a slide just to show that we need to well manage the use of nephrotoxics, avoiding co-utilizations, aminozides, beware vancomycin, acyclovir, etc., etc. And are there hopeful drugs for the future? Question mark, uncertain future. Future is always uncertain, as we know, but these are uncertain drugs of the future. Or the uncertain future of drugs of the future. Maybe that's what should be said. So I've nominated for you phosphatase alkaline, the extracorporeal treatment cytophosphoretine, and mitochondrial drugs. So toxin through dephosphorylation that rises adenosine that has protection against inflammation. Maybe discuss that it reduces NO active in tubular cells, proximal, and also these levels are reduced in AKI. So there's a first phase 2 study performed in 36 patients with severe sepsis with or without kidney failure, randomized 2.1, 25 treated, 11 control, a full population. Triangles is placebo, the square's AP. On creatinine, not much difference. Maybe it takes off a little at the end after 48 hours. However, in patients with renal failure, in the group treated with AP, we have a reduction in creatinine, whereas it continues to rise in group with severe sepsis controlled patients without renal failure. Not much difference, and we find this difference in creatinine when we've coupled certain predictive markers of AKI mentioned at length in this symposium. Second study, phosphatase, alkaline, and AKI of septic shock. 36 patients, severe sepsis, septic shock with AKI, randomized PA versus placebo. Here are the results on creatinine clearance. We see clearly in the PA group, creatinine clearance is lower than in the control group. Patients have less need for RRT, and the RRT durations in patients that need it is reduced in the AP group. So there's an avenue there, and a trial currently underway internationally on this product. If we now consider mediators associated with AKI, it works, or at least I've selected those for which it worked. KIM1 lower in the PA, IM18 is lower, interleukin 6 representing pro-inflammatory cytokines lower in the PA group. Second treatment approach, not directly a drug. The drug exists, but it's placed in extracorporeal, a membrane, and a membrane that has a of sequestering and inhibited the activated cytokines. It's polysulfone. When it's mixed with citrate, that is what activates it on the activated leukocytes. In feasibility study, 25 patients with AKI requiring RRT, no contraindication to citrate, sepsis, or with a failure of another organ than the kidney. What we see, of course, these are very limited populations because these are preliminary studies that I'm presenting. Well, we see that survival seems good, and that the markers or certain biomarkers for the activated leukocytes going in the right direction, that is, the leukocyte inflammatory development is slightly improved. So a target that we mentioned yesterday, if we were to look at mitochondrial activation for reperfusion and mitochondrial activation, either they need to be regenerated. When they're in poor shape, they deteriorate. They can fusion and assume strange shapes, can also be reduced and consumed in reaction to this inflammatory reaction. So this might well appear, and in fact you can find this in this general review. This might be a pathway for new treatment targets, either by preventing mitochondrial aggression by using antioxidants. We know that it's the seat of oxidation, and there we could perhaps possibly reduce the impairment of mitochondrial fusion, accelerate the clearance, mitochondrial clearance, and promote mitochondrial biogenesis with gamma coactivators, which is a transcriptional co-activator with animal studies that are of interest. So watch this space. We're in very preliminary phases. To my knowledge, there are no human studies with this type of product. So in conclusion, very simple, clear, no to nephrotoxics. Be careful in their use in the event of shock, and history of hypertension, possibly up the dose of arterial pressure. Not use diuretics, but maybe think about what we do in patients with fluid overload, and possibly a mix with the two presentations that are my predecessor and my own. And I fully agree with what the previous speaker said, where we can perhaps ease up in terms of fluid balance, not diuretics, because there are no studies in that situation, but possibly have some more studies on that. And the new drugs, we need to track what's